Hello, everyone. For this first lab, we're going to go over the principles of examination. That's for you to gain an overview of how the process of examination goes through it for musculoskeletal injury. So I kind of want you to have this understanding before you go to the lab. So in athletic therapy, there's two main form of assessments or examination. There's the one we do on the field or on the sideline, and the one we do in the clinic. So on the field and the sideline, our main concern is obviously to determine the nature of the condition, but really we want to know, is it life-threatening? Can it lead to severe disability? Do we need to call the ambulance? Do we need to refer them to a doctor ASAP? What kind of care do we need to provide right away? And if there's, if the condition is not serious, can the athlete return to play? In a clinic, again, we want to determine the nature of the condition. We want to identify potential red flags that may be requiring some medical attention. But mainly, we want to gather all the information necessary so that we can establish a rehab plan. That includes what activities can the athlete still do to maintain conditioning? How are we going to modify them? Or is there some activities that may result in aggravating the injury? Let's start with the clinical assessment because it's more comprehensive. It has more components and we go more in depth in it so that when we see the on field or sideline assessment, it'll be easier to go through. So there are three components to this type of examination. The first part is the patient history, and then the subjective examination and the objective examination. This is where we're going to gather our information to establish our clinical impression and prepare the rehab plan. So the patient history is all the information that the patient can tell you that will help you determine what the functional needs of that patient are. So what kind of activities they're doing, what are we striving for or driving for with our rehab plan. And it's a first step into developing a relationship that is based on trust with the patient. Information that we need to gather is the age, sex of the patient. Obviously, it's supposed to say identity, so how they identify. It's important to make the athlete feel safe and that they can trust you and make them feel secure. So it's important to take that into consideration as well. What sport are they playing? What position are they playing? And what's their role? So are they a starter? How many minutes do they play? Are they somebody that only play a few minutes? Are they next in line if something goes bad? Are they at risk of losing that position? So what are the implications of them being away from their sport? Then we want to ask them about other occupations, so whether they're students, whether they have a part-time job, and what are the tasks relevant to this occupation that may impact their injury. So if they're students, how are they traveling to and from school if it's not a pandemic, obviously? How much time does it take? Are they using the public transport? Also, how much time are they spending sitting, standing, or in a prolonged position at each of these occupations, and how this may impact their pain or their condition. And then training. So we want to know how many practices a week they have, what they do in a practice, but we also want to know about, do they have additional workouts, the frequency, the duration, the intensity, and the goals of their workout. Are they working hypertrophy? Are they trying to lean down? Because we may have to modify those activities so that they don't make their injury worse. And what kind of social support they have. Like, do they have somebody that can help them at home, somebody that can drive them to different appointments, somebody that can listen to them if they are struggling with their injury mentally or psychologically. So who's around them to help them? And then we want to have a history of their, like a medical history. So we can use the sample acronym to make sure that we get a general overview of all their medical history. So subjective, it's typically related to the current condition. So we'll see that more in depth in the next slide. But do they have any allergies? Why we ask? Because there are some treatment or interventions that it may affect. So for example, they're allergic to glue or latex, uh, it might be preferable to not apply the glue or tape directly on the skin if we want to do a taping. Are they taking any medication? Is there any medication that may cause some side effects that can make the injury worse? So if it's a concussion, are they any medication that have side effects that are similar to the symptoms of a concussion? That kind of information we need to gather. Do they have any medical condition that we need to take into consideration? Do they have diabetes that may delay the recovery of the tissue? Do they have cardiac issues? Do they have any lack of sensation that may impact our application of cold or heat or electrotherapy? Um, in the simple, the L's typically stand for last meal. It's not really relevant in a clinical setting, but we might be able to ask them about their appetite. Does the injury influence their appetite? How, and gain a general sense of how they typically deal with nutrition. And finally, we want to know, do they have any injuries? Have they injured that body part before? Was it similar? Any other injuries anywhere else? Because maybe their current injury is caused by another injury that was not properly recovered. So we kind of want to know what's going on in the body, so that is there something up or down the chain that may affect the recovery of the current pathology. Um, then we want to be more specific to the injury, and then we do the subjective evaluation or assessment. We can use the acronym OPQRST. O stands for onset, where we want to know how and when the injury happened, or when did the pain start, what were they doing. So what is the mechanism? Injury. uh, so the more we know about the mechanism of injury, the better we can narrow down our suspicions to fewer hypotheses, uh, so that we can identify which structure is more likely to be injured. Because there is a strong relationship between mechanism of injury and what body part of the body is injured, and we're going to see that throughout the semester. Provocation, so what increases or decreases the pain. You can ask the question as is, but then you want to be more specific to the sport and occupation. Have they tried some part of the activity? Um, and also, is there any activities of daily living that cause pain? What have they done to mitigate the pain? Have they been putting ice? Is there a position that decreases the pain? And have they been taking some medication? So what have they been doing to mitigate pain? Q stands for quality. So we want to know what kind of pain are they feeling. Is it a sharp pain, so which means more acute, a dull pain that is more chronic, a tropic pain, a burning pain, so burning, tingling, numbness, typically more associated with either a vascular or a neuro injury. So we kind of want to know what we're dealing with here. R stand for region. Where does it hurt, and is it like local, or is there some irradiation, like radiation that goes down the arm or up the arm, down the leg? So we kind of want to have an idea of where the pain is located, because, well, the structures that are in that region are the ones that are most likely to be injured. S stands for severity. So the severity of injury does not give us a lot of information, in terms of what the pathology might be, because this how people experience pain is very personal. But it's a great way to kind of monitor progress, because if the pain used to be an 8 out of 10 and now it's a 3 out of 10, then it's progress. That means the condition is getting better. So we ask them to rate their pain on a scale of 0 to 10, but we need to set boundaries. So 0 is no pain, and 10 is they got hit by a train. Some people say 10 is the most pain you've ever felt in your life. But if it's the first time they get injured, most likely this will be the most pain they ever felt in their life. So it's not a good indicator for that reason. It can help a bit narrow down, as some injuries are more painful than others. So like a fracture will be more 8, 9, 10, but not because they have 8, 9, 10 out of 10 means it's a fracture. Some people may have a bruise and say they have a 9 out of 10. So it's very difficult to narrow down your suspicion based on that severity. And finally, timing, T for timing, which you want to know, is there a time of the day where the pain is worse? Is it in the morning, or is it after a full day of work? Is it constant? Is it intermittent? Like, does it come and go multiple times during the day? Is it based on position? Is it based on activity? So we want to gather more information here. Other important factors that we may want to ask our patient is, how are they sleeping? Sleeping is when the body rebuilds the injured structures. So if they're not sleeping well, they're not recovering. Do they have a proper nutrition to fuel that recovery, help with sleeping? Or do they have a type of nutrition that is really pro-inflammatory? Do they have a lot of stress and anxiety and may contribute to a delayed recovery? What's their current relationship, or how do they communicate with coaches? That's also important, because it might cause some stress and anxiety. And are they under some external pressure from either the coaches, their parents, their teammates, their girlfriend, boyfriend, anybody else that may cause some stress and anxiety, that may cause them to not have a open communication with you. So you want to assess like a full picture with these additional questions. So on the right side, you have the biopsychosocial approach to pain and injury. So it has 3 components, and all 3 of them can influence how a patient perceives their pain or their injury, and may influence how they recover, how they adhere to your treatment plan. So that's why we asked all these additional questions, so that we can have a clear understanding. And if there are some issues, you may want to refer to the relevant healthcare professional so that the athlete can get the help they need. These are some red flags that if the patient reports them, then they should see a medical professional as soon as possible, as they may be an indicator of conditions such as cancer or severe neurological or injury. So severe pain that won't go away, pain that is unaffected by medication or body position, severe pain at night that wakes up the patient, severe pain but no history of injury, or no repetitive movement, severe spasm, inability to urinate or incontinence, elevated temperature, whether it's local or general, especially if it's prolonged, because it may be an indicator of infection, and if there's a very obvious psychological component where some of the pain may be caused or may be exacerbated by a psychological condition. And all that is to lead you to have 2 or 3 hypotheses of what the pathology or the condition is. So based on a history and a subjective examination, your mechanism of injury, the location of the pain, and how it presents will lead you to 2, 3 ideas. And that is called a differential diagnosis. And then what you're going to do is perform the objective examination so that you narrow it down, hopefully, to just one, which is your clinical impression. As a lead healthcare professional, we have clinical impression. Doctors have diagnosis. So we are not allowed to say that we have a diagnosis. We have a clinical impression.